HIV and AIDS. So I'm actually an old guy who remembers before we had very effective treatment for HIV and when the majority of people did actually progress to actual AIDS. Um, I'm going to talk about a lot of the complications that we saw back then and some of the drugs that we treated them with. They still do occur, but they don't occur very often anymore. And right now, the treatment for AIDS is actually being pretty well funded. But if you go to Africa or if you go to other parts of the world, you're going to see these complications. So I don't think there's anybody around that really doesn't know how you get HIV. So men that have sex with men, heterosexual contact, IV drug use, needle sticks, splashes, in utero, lots of different ways. So back in the 80s, the term AIDS and HIV were just being identified. In 1981, there were 6 cases of pneumocystis carini pneumonia. We now call it pneumocystis jirovecii pneumonia, but PCP, and 26 cases of Kaposi sarcoma. Essentially, all of these were found in gay men. And we thought, geez, maybe it's related to something called poppers. Poppers is amyl nitrate. It's actually a drug that a lot of gay men were using that they thought improved their sexual experiences. And they thought, well, geez, this is what's causing it. And they called it gay-related immune deficiency because they did see that people's lymphocyte counts were very low, especially CD4. There were 2 different people that isolated the virus, one in France, one in the United States, and they did actually find that virus about 3 years later. I would highly encourage reading the book And the Band Played On if you're interested about the history of HIV. So there's about 37 million people in the United States that have HIV, in the world that have HIV or AIDS. This is fairly stable. It's been stable for 10 years or more. 67% of these are still in Africa, 500,000 or more in the US, although there may be as many as 3 million people since a lot of them are undiagnosed. And that's more than the population of California, and it's more than the population of Maine, New Hampshire, Vermont, Massachusetts, Connecticut, Rhode Island, and New York combined. So primary prevention, that's actually the 37 million is greater than that population. Primary prevention, we try to keep people from getting the virus and getting the disease. So they use clean needles, they avoid at-risk sexual behaviors. And now we're using a medication for pre-exposure prophylaxis that we'll talk about in a little bit. And again, you try to prevent people from becoming pregnant with HIV. Secondary prevention. So now secondary prevention is basically early case finding. In cancer, you try to do that so you can then cure them. In HIV, we try to do that so that we can control them because there really is not a cure for HIV, but it is a drug that is pretty easily controlled using medications at this point. Tertiary prevention, so basically after people have HIV and they have bad things happen to them, how can we maximize their function? So cryptosporidium is a problem that occurs that causes diarrhea. AIDS dementia was pretty severe and a problem years ago. Candidiasis can be very severe. CMV, cytomegalovirus, retinitis is a virus, lymphomas, and cervical cancer. Interestingly, all of these are related to things that lymphocytes, and especially the CD4 lymphocytes, take care of. So if you have a strep throat and you have HIV, you're going to be just fine because the strep throat is not something that the lymphocytes take care of. It's something that the neutrophils take care of. So you're going to be just fine. If you have any of these things and your CD4 count is low, you're going to have big problems. So why do these people get these issues? Because their immune system, specifically the CD4 counts are low, and that's because a retrovirus, i.e. HIV, and usually HIV-1, but HIV-2 is getting more popular in the world. So it invades the cells and interferes with the CD4 antigen function. and it starts writing these codes backwards, and that's why they call them a retrovirus, is because they rewrites the DNA and the RNA, mostly the RNA, that writes the codes backwards. And when this happens, the cell just doesn't function correctly. It basically bursts, and then more virus is released and infects other cells, and the process goes on. So we notice a lack of effect of those T lymphocytes, and the T lymphocytes usually fight off protozoal, fungal, and other viral threats. And so the body gets these kinds of infections. We can test for antibodies to the virus. We also test for the viral load. Usually the viral load we're looking for is undetectable, and so we never say 0 because we assume that there may be some there that we can't detect. But we are reassured by the fact that it is undetectable, and that is a very good sign for someone with HIV or hepatitis B or hepatitis C. Primary infection, they'll usually, when they first get HIV, they feel like they have the flu. And this is on your differential. It's usually a few weeks after the exposure. There's not really anything we can do about it. And in fact, unless you do the right test, they won't even test positive. Some of the newer tests can catch them and make them positive, although the older antibody tests, which we often rely on, will not show a positive test at this point. Treatments, basically, we're going to address the treatments of HIV itself and the treatments of some of the HIV complications. So pneumocystis pneumonia, and usually it's abbreviated PCP for pneumocystis, for that C. Used to be called pneumocystis carinii pneumonia. Now it's called pneumocystis jirovecii pneumonia. Either way, we usually still call it PCP. If an AIDS patient is not treated with antiretroviral drugs, about 75% of them will get it. Interestingly, it used to be classified as a protozoa. It was reclassified about 15 years ago, and it's now considered to be a fungus. It's fascinating that it responds to Bactrim, because I always think of Bactrim as an antibiotic, not an antifungal. And that's why I think oftentimes when we talk about these medicines, antimicrobial is a more accurate description of them, because many of them do have cross effectiveness with some other issues. Flagyl is a classic example of that. It kills a lot of bacteria, but it kills some protozoa and some fungi as well. So toxo is a protozoa. It's basically a parasite. And in HIV patients, it can actually go to the brain and cause encephalitis. Normally, we don't worry about it. It's a self-limiting disease in which people feel like they have a very low-grade flu. Not much for fever. They feel achy, maybe a little bit of nausea and vomiting. In pregnant women, it's a big deal because it actually can cause defects in the baby. But in other people, we just don't even diagnose it, and it is a hard condition to diagnose. In HIV patients, though, it can go to their brain, and you do need to use treatments that we would normally use for malaria, and they are pretty substantial medicines. Tuberculosis, again, it's a bacterium. It's a mycobacterium, and mycobacterium means it has some sort of fungal-like qualities. It's got a very thick cell wall, very hard to treat. In HIV, you really don't have the ability to fight it off like you would, if you have intact CD4 cells. It can go to the lungs, which is the classic, but it could also go to your meninges, go to your spine, and other organs. It requires multiple drugs, at least 2, usually 3. A lot of multi-drug resistant tuberculosis is increasing in the world. It is a real problem in North Korea. Usually you're treated for 6 to 9 months, and there's 10 drugs that are approved, and as noted, the usual treatment is at least 2, usually 3. Kaposi sarcoma is a skin condition which is Usually found often on the lower extremities of HIV patients if they are untreated. We think it's possibly related to herpes simplex virus, but we're not sure of that. It looks like a raised bruise, and it's pretty uncommon at this point. Again, that was obviously the way that we first found HIV. If someone has this, you just put them on HAART, which is highly active antiretroviral therapy, an abbreviation that is falling out of vogue in some places, but is often still used. And again, since it is a cancer, it's a sarcoma, which is a cancer of connective tissue. It can be used to use chemotherapy agents. Mycobacterium avium complex, or Mycobacterium avium intracellulare. We said that tuberculosis is a mycobacterium. This is also a mycobacterium. For most people, they really do not get any symptoms with it. Again, if you're immunosuppressed, you can get meningitis, you can have a wasting syndrome, you can have diarrhea, sweats, and the treatment is, again, it's a mycobacterium, but we'll use aggressive antibacterial and thiamutol and rifabutin, which are medicines that are mostly for mycobacteria. Cryptosporidium is a protozoa. It can cause diarrhea. It's hard because Cryptococcus, which is kind of similar, is a fungus, so that's a lot harder to figure out and can also happen in HIV patients. But Cryptosporidium is a diarrhea. It almost always is self-limiting. Usually it cures itself. Oftentimes when we test for Giardia now, the Giardia test will also test for Cryptosporidium. The treatment is nitazoxanide twice a day for 3 days. As of right now, that's $750 on GoodRx, but you can imagine that if one has HIV, you probably do want to treat these people if they have gone to frank AIDS. Frank AIDS is a CD4 count of under 200 or having one of these opportunistic infections. AIDS dementia, the virus actually works directly on the brain and can be very severe. Yeast, candidiasis. Thrush is common, but it also can affect the brain. If you get meningitis, then we use amphotericin, which is sort of the big kahuna for antifungal treatments intravenously. Fluconazole, which is diflucan, may be effective if it's very mild, or once somebody's had a long course of IV and you just want to keep them on oral for a few weeks more. CMV retinitis affects the eyes, obviously, the retina, and it is just an antiviral. Cyclovir is the suffix that all the antivirals, acyclovir, famciclovir, valacyclovir, all of those have that same suffix. Lymphomas may have a viral cofactor. And again, AIDS might be that viral cofactor, and steroids can interfere with the function of the lymphocytes. So obviously, you may actually use those to treat this. Cervical cancer, HPV is the issue here, but in combination with HIV, it tends to really accelerate the process. You can use surgical treatment, remove the uterus. The 10-year effectiveness of Gardasil does seem to really be panning out. This article here, I've posted the link also on the Blackboard, really does show that in the cervical cancers that are being found, that far fewer of them are testing for HPV positivity, and that the overall incidence is actually going down. So HIV treatment itself, we have had really good luck with this. It's obviously not a cure, but it is very effective at keeping those CD4 counts up. And if you keep the CD4 counts up, you don't get any of these opportunistic infections. So there's multiple antivirals that are used. Almost all of these are antiretrovirals. They specifically block the process of reverse transcription. The most common two are the nucleosides and the non-nucleosides. And the protease inhibitors also interfere with certain protein precursors so that it can't be turned into the proteins that the virus needs to complete its replication. The NTRIs basically block the reverse transcription directly. A nucleoside is kind of one of the building blocks of DNA, and so it gets right in there and stops it. The NNTRIs do basically the same thing, but they do it by binding to the enzyme instead of actually interfering directly. So the usual treatment right now, I've posted a link there that really does talk about it. Traditionally, we use 3 drugs, maybe 3 of one, maybe 2 of one, but either way, we have to use 3 drugs, and more commonly, it's a combination of reverse transcriptase inhibitors and protease inhibitors. Now, PrEP is an interesting thing. PrEP is pre-exposure prophylaxis. If you have someone that is having a lot of at-risk sexual activity, usually young gay men, you start them on Truvada. It includes those 2 medicines there, and it decreases the risk of sexual transmission by 99%. It also increases even the risk of IV drug use transmission by 74%. So it's a pretty amazing medication. Most insurances pay for it without flinching, just because it's much cheaper to pay for this than it is to pay for HIV and AIDS and lifelong complications. Now, PEP, or post-exposure prophylaxis, is usually divided into 2 major categories. One is occupational, and then the other is non-occupational. So usually they put an N in front of it for non-occupational, and you can see the usual treatment here includes multiple medications, and usually it's a 28-day course. And then for occupational, it is also usually a 3-drug treatment. We used to use just plain AZT, but the feeling is that there's too many side effects and that it's not as effective as the multiple. It's a little bit more flexible as far as the duration, just because if you have a source patient and they test negative, then you have a decision point of whether they might be in the window phase. But either way, it's often got infectious disease specialists involved, and they're helpful in making those kinds of decisions. And here's some drugs of the week. Obviously, some of these you've seen before, but think about them specifically in relation to HIV if you would.